Hello everyone, welcome to the EPSRC Digital Health Hub for Antimicrobial Resistance lecture series. My name is Professor Rachel McKendry. I am from UCL, from the London Centre for Nanotechnology and Division of Medicine, and I'm here together with Elliott Rogers. And today we're going to be telling you about smartphone-connected rapid tests for infectious diseases and AMR. So by way of introduction, here's a photograph of my group on the left at UCL. I have a small research team, but collaborate widely with researchers. And the photo on the right is our large EPSRC interdisciplinary research collaboration called iSense. If there's anything that you find interesting in the lecture or want to find out more, please contact me. And I've put my email and websites at the bottom of the slide. Okay, so let's look at the 5 learning objectives from the lecture today. The first is a brief recap on the importance of rapid diagnostic tests for antimicrobial resistance. If you've been watching the lecture series, you will have heard about this in previous lectures. The second objective is to give an introduction to connected diagnostic tests and why they are important. We're then going to look at 3 case studies. The first is from my own research groups working with the Africa Health Research Institute, and this is on diagnostic decision support tools. I'll then be handing over to Elliott, who will give 2 further case studies from other research teams around the world, one on rapid test visual assessment and the third on treatment and patient management. So these are really nice examples from the literature that we're delighted to share with you. The 4th learning objective then will come back to the Digital Health Hub for AMR with a focus on our Grand Challenge project. And at the end, we'll give you some suggestions for further reading. Okay, let's start with the pre-reading. So these are some suggested pre-reads. The first is an introduction to the review on antimicrobial resistance, which was put together brilliantly by Jim O'Neill. The second is a paper in Nature Microbiology on reassured diagnostics that my colleague Rosanna Peeling led. The third is one of our reviews with Molly on taking diagnostics, mobile diagnostics to the field. And the last one is a review that my group led looking at the lessons learned from COVID-19. So the links and the journals are shown here. So let's start with that brief recap and an introduction to rapid tests for antimicrobial resistance. And I've already signposted this very important review in the field. It's called the Review of Antimicrobial Resistant Infections, Tackling Drug-Resistant Infections Globally, and was led by Jim O'Neill's team. So this infographic slide summarizes the problem. Rapid diagnostic tests would play a crucial role in reducing unnecessary prescription of antibiotics. So out of the 40 million people who get antibiotics for respiratory issues annually in the USA, you can see from this infographic, the ones in dark purple or blue, 13 million, are those who need antibiotics and get them. The rest, the other purple heads, are the 27 million people who get antibiotics unnecessarily. So there's a huge issue in inappropriate prescribing. The review very nicely highlights the importance of rapid diagnostic tests. So here you can see a sick patient at the top might present at a doctor. There's then an empirical diagnosis traditionally, but treatment is given, although may fail, and a second option is given. But the optimal treatment may never be achieved. In the middle pathway, you can see a diagnostic test is given, but if you have to send the sample off to a central lab, the optimal treatment is delayed. And on the right-hand side, you can see in the blue circle, the ideal positioning of a rapid diagnostic test, where within a single patient visit, a test is undertaken, the result is given back to the doctor and the patient, and a prescription is given if needed. So now let's look at the ideal characteristics of a rapid diagnostic test. And this is the paper that I was highlighting by my colleague Rosanna Peeling. She coined the phrase reassured. And it's an important acronym which determines these characteristics. An ideal test should have real-time data connectivity, for R. E stands for ease of specimen collection. A, they need to be affordable to those in need. S for sensitive. S for specific, U for user-friendly, R for rapid and robust, E for equipment-free or environmentally friendly, and D for delivered. And on the right-hand side, you can see this pyramid, which shows the different levels of the health system and the different types of tests that can work in each setting. At the very top, you have the nationalist specialist centres, and at the very bottom of the pyramid, in green, the community. And this is really an important area where testing is much needed. But below, you can see there are trade-offs between the accuracy, accessibility, and affordability of the tests. In my group, we are really excited about the use of lateral flow tests. And of course, during the pandemic, this very simple format has reached further than any other diagnostic platform. They work by taking advantage of the natural capillarity of paper, and gold nanoparticles of a very specific size bind on the test line, creating a red colour that you will have interpreted as determining if you had COVID or not. But this relies on very subjective human interpretation, and we can make errors, typically with very faint lines. So there are challenges with these tests. There's also no automatic data capture, and that risks data loss. So for example, in the review, we highlighted that only 14% of COVID rapid tests were reported in the UK within a certain time frame within the pandemic. But more broadly, these tests have huge potential. They're already used in their millions around the world. Here you can see 345 million malaria rapid tests were deployed in sub-Saharan Africa in 2022. Gavi are shipping over 1 million cholera tests in 2024 as part of the eradication programme for cholera, and for HIV, over 2 million rapid tests projected for 2027. And we believe that these tests could be very important in tackling AMR. And in this lecture today, I'm going to focus on the connectivity challenge. So, what are connected diagnostics? I've taken the definition here from PATH, and the reference is shown below. Connected diagnostics are diagnostic systems that are digitalised to adapt and integrate with the broader healthcare ecosystem in order to improve the accuracy, efficiency, and accessibility of medical diagnostic technologies and data. So here you can see in the middle a smartphone connected to a lateral flow strip where the data and the connectivity is shown to patients, healthcare workers, governance organisations, ministries of health and the community. So it's really important to engage with all these different stakeholders. This is one of our reviews with Molly Stevens, where we looked at different smartphones and sensors that are embedded within smartphones, including accelerometers, cameras, microphones, and other devices that can connect to your phone, to explore the opportunities and the challenges of using them as connected diagnostics. And here you can see in green some of the advantages of connected diagnostics, taking advantage of the processing power, the screen, and the geospatial connectivity of your phone. A phone can provide a step-by-step guide to using the diagnostic, when to take the sample, when to read the test, for example. It can also capture results from the test and transfer the results into electronic patient records, and if necessary, can do on-device or cloud-based analysis. But the key thing is where the data goes. So it can feed to patients for remote consultation or improved linkage to care if someone might be self-testing at home. It's important for healthcare workers, supporting decision-making and reducing the burden of paper-based reporting. The data is important for clinics, for supply chain management and disease surveillance, as well as public health systems to look at the spread of disease, but also the efficacy of interventions. And it is really crucial that this data is stored. So here are a few examples from my own team that you can see in the images. You can use a smartphone camera to capture an image of a lateral flow strip on the left. In the middle, we've teamed up with Idegern Ozkan's group in UCLA to develop a photonic device that sits on the back of the phone. We're looking at highly multiplexed assays, so you can see already that it would be very hard to interpret a test that had multiple lines by eye. And on the right, you can see an example that's not our own. It's from Oxford Nanopore, but shows the future of sequencing linked to a smartphone. So this is a hugely exciting field, and we and others are working to develop these sorts of connected diagnostic tests. We also began looking at one of the key sensors in your phone, your smartphone camera. Of course, we all like them to take pictures of the world or maybe selfies, and we've been charting their properties and adoption around the world. So in this graph, you can see in red, smartphone adoption worldwide, and in blue, smartphone adoption across sub-Saharan Africa through these years. We've also been looking at the camera properties, the number of megapixels, with small dots representing 5 megapixels up to 20 for larger ones, and looking at the price points for high and low end phones, in grey for low cost and black for high end phones. And essentially what you can see, we know the smartphone revolution has exploded. Sub-Saharan Africa is slightly further behind, at least to start with, but it's absolutely catching up. And the difference in performance between high and low end phones is converging. So there's a really exciting opportunity to use smartphones for health. But I'll flag up, there is still a long way to go, and it's not a silver bullet. This mapping work, again done by Joby Budd, who was a brilliant PhD student in my group, focuses on Uganda. And what Joby's done is to remap publicly available data, open source data, mapping network connectivity for phones, shown in these colours, with population densities, and he's taken the locations of different healthcare facilities shown by the dots. And essentially you can see large parts of the country in grey have no network coverage, whereas around the big cities we're seeing high levels of 4G coverage. And this is just a good example also where we can see how mobile phones could be used in a very targeted way to support health systems in resource-limited settings. So focusing on areas currently where there's good network coverage, but there are populations who would have to travel more than 5 kilometres to reach a healthcare facility. So we have been in discussions with Africa CDC about using these approaches more broadly across Africa. Okay, so now we're going to focus on some case studies, and I will start with the case study on using these methods as a diagnostic decision support tool. And I'll start by highlighting this is a very strong collaboration with the Africa Health Research Institute, an excellent research institute in South Africa. This is an example of our work. It's a true partnership where we've been co-creating technologies, working with field workers, nurses, community workers to understand and co-develop technologies to help tackle the huge challenge of HIV in this setting. It has focused on developing smartphone connected tests, but also data dashboards to help understand where mobile health could be most impactful in this setting. So the work was published in this journal, Nature Medicine, and began to explore how we could use deep learning as a decision support tool for HIV. Now I'll flag up this work started in 2017, so way before the pandemic, but these HIV tests were being widely used in this setting and elsewhere. You can see from the map that KwaZulu-Natal is just north of Durban in South Africa, and this is where the setting that we worked. We began to explore how these two types of tests that were already being used within surveillance, within RE, could be adapted for deep learning approaches. The two tests, when you first look at them, look slightly different. One's curved at the top, one's quite rectangular. But when you crop around the region of interest, this red box, you can see that the two tests look very similar. And as a reminder, a single test line is a negative test and two test lines are positive. And in this setting at that time in 2017, it's worth bearing in mind there was 45% HIV prevalence in antenatal clinics, 9.5% of HIV incident in young girls aged between 15 and 19. 30% of people were unaware of their status, and only 50% of those diagnosed were reaching care within 1 year. So a hugely challenging setting, but one where interventions can make a huge difference. And this graph below is not our own work, but it shows the introduction of antiretroviral therapy in 2004 led to an 11-year improvement in life expectancy in this important population. So linkage to treatment is really key. And here you can see the setting. It's a very rural setting in KwaZulu-Natal. And we began to explore how could we use this decision support tool to support field workers. So in blue, you can see now the workflow, which was happening when we started the collaboration. A HIV rapid test was performed by a field worker. The field worker visually interpreted the test, and the results were communicated to the participant. But we began to explore what would happen with a connected test where a photograph of the test was taken, an automated image classifier determined if it was positive or negative. The results were then communicated to the participant and uploaded into a secure database. And the advantage of this approach is that there's no data loss. The data links into laboratory information systems, stock supply management, staff training for particular members of staff who found it more difficult to interpret a test, quality control of the tests, which can vary, but really key in future, it's the linkage to care and connectivity into wider surveillance systems. Now, we haven't achieved all of those points on the right, but today I'm going to tell you about the first step, which is the classification of test results. So here you can see the image library, which was really crucial to this work. At the time, researchers in the field had simply been taking photographs of lateral flow tests in the laboratory. But that's not the real world setting. So we set about working with over 60 field workers to acquire a real world image library. So each of these rectangles is that region of interest in the lateral flow test. And these tests were taken in those rural homesteads by field workers. And you can see some appear slightly blue, some are more shaded. There's a huge variety of a real-world image library. And we set about using that. This is just a snapshot, 162 of the 11,000 images. We also looked through interviews with both the fieldworker staff and the patients to see if this was acceptable and feasible as part of their work and their daily work. And the participant consent rate was found to be very high, over 96% of those that had accepted to test. So this was really encouraging. And I'd say this was the largest field-acquired image library pre-COVID. So then we began to look at exploring different approaches and different models to train using this data set, initially developing our own, but then turning to models that already existed, Mobile NetV2, NetV3, ResNet50 and SVM, and using a tenfold cross-validation approach, accounting for class imbalance, and using ROC curves on the validation set, we were able to look at the sensitivity and specificity of these two different test types, test A and test B, with our data set. And all data training and evaluation was done using scikit-learn and TensorFlow libraries in Python. But here you can see the model that performed best in our hands was Mobile NetV2, with very high levels of sensitivity in grey and specificity for both test types. So we went ahead with that model. Now, just before lockdown, we were able to do a small pilot study together. It was a much smaller study, but we used those algorithms, which we saw were very good at classifying if a test was positive or negative. And in this study, it was a pilot study with users. The first step was to develop an app through an iterative process with peer navigators. It was a relatively small number of participants, but comparable to other studies in the field. And the participants, who were nurses and community health workers, showed that it was entirely feasible with virtually no training to capture an image of the test. We overlaid this guideline, and the guidance was given in isiZulu and English, and the images were captured. We then asked the nurses and community workers to interpret the tests. This was for each pair of participants. There were 38 HIV rapid tests. On the left, for test type A, you could see there was 100% agreement between the two nurses. But for the community field workers, it became more variable, between 80 and 90% agreement, even on a small number of tests. But for test type B, it's quite a different story. Even between the nurses, there was disagreement, although only in a small way. But between the community health workers, we saw the largest differences in their ability to determine if the test was positive or negative, with results in terms of agreement varying from 61 to 100%. So this highlights the need for a decision support tool. And in this study, we compared the performance of our deep learning system to this visual inspection by nurses and community health workers. So this was not yet done on the phone. It was done on a secure server, but the results were really encouraging. So what we can see is that our deep learning system, which we call Classify, was able to significantly reduce the number of false positives. So in that study, there were 11 false positives by the nurses and the community workers, and we reduced that to 0. And in terms of the false negatives, we were able to reduce that from 4 to 2. So this led to a significant boost in specificity from 89% to 100%. So that's an 11-fold improvement in specificity. And also a 2.3% improvement in sensitivity, so increasing it from 95.7 to 98%. But these results are really important to ensure that people aren't incorrectly diagnosed, that they have HIV when they do not, and also equally that we don't miss cases. And if you consider, back to one of my earlier slides, that there are potentially hundreds of millions of these tests performed annually, even this small improvement in quality assurance could impact the lives of millions of people. We made these algorithms open source and publicly available. Here you can see it was also on the front cover of Nature Medicine. During the pandemic, we were approached and asked for help with other COVID assays, and we worked with the REACT study. So 500,000 lateral flow test images were uploaded, and the algorithms showed equally high levels of sensitivity and specificity for COVID tests. We're also now exploring applications in cholera, working with Johns Hopkins and teams in Bangladesh. And our work has been highlighted in the 100 Days mission, in this report that you can see on the right, about the future of connected diagnostics. And it's seen as one of the key priorities now in pandemic preparedness for the future. Okay, I'm now going to hand over to Elliott, who's going to tell you about case study 2 and 3. And just to highlight again, this is not our work, this is work from other researchers in the field that we think is important for this lecture.
Thank you, Rachel. It's my pleasure to be joining this lecture series. I'll be walking through the next 2 case studies. So first of all, case study 2, IDT visual assessment. This case study adds to the evidence of the need of these support tools for IDT classification and for connected rapid tests. So this is the SMS photograph-based external quality assessment of reading and interpretation of malaria IDTs in the Democratic Republic of the Congo. In this work, the assessment of IDTs was evaluated for 2,344 different health workers for malaria IDT images. There were common errors of reading or interpreting faint or weak lines incorrectly. So in the bottom left, we can see an image of a malaria IDT. This result has a weak positive line for the P. falciparum result, and only 54% of health workers were able to classify this correctly. And as we can see here, 29% read this as a false negative. So very common errors here of incorrect classification of a visually interpreted test. And here the performance of non-laboratory and laboratory staff was similar. And the results show that dedicated training improved accuracy of IDT assessment. So this digital connection of rapid tests extends past just interpreting results, but it also goes into training and assessment of individuals' ability to assess IDTs. The next case study here is looking at the treatment and patient management. So a bit of background here. C-reactive protein, CRP, is a protein that's produced by the liver. CRP concentrations rise during infection, trauma, pancreatitis, myocardial infarction, and surgery. And this acts as a non-specific marker of infections of bacteria or viruses. On the right-hand side here, we can see the 3D protein structure of CRP. It's a reasonably sensitive test, but we can also see false positives. And CRP levels start rising just hours after infection and peak around 24 to 48 hours post-infection. So you can really miss those early aggressive infections. But this marker is key in tackling AMR and reducing antibiotic prescription, and can be used and is integrated into clinical pathways for guiding antibiotic prescription. Semi-quantitative CRP IDTs currently form part of the NICE guidelines in the UK for lower respiratory tract infections in primary care. A recent expert review committee stated that more rapid and accurate diagnostic testing and the integration of data into digital dashboards can help guide decision-making in a real-time manner when discussing CRP testing. And on the right-hand side, we can see that CRP point-of-care testing is just one of the key pillars that we have in tackling AMR. And on the left-hand side, we can see quite a complicated result for the CRP RDT, with here on the left-hand side, the negative result, and on the right-hand side, after 5 minutes, 3 different positive results that can be interpreted visually. And as we've seen in the HIV case study and the last case study on malaria, these RDTs are prone to be read incorrectly. So it's very important here to have digital tools that can support in the classification of these results and also aid in training and education of individuals who will be reading these RDTs. So this brings me on to the case study that we'll be looking at here. This is a digital health algorithm to guide antibiotic prescription in pediatric outpatient care. And this is a cluster randomized control trial where 20 primary health facilities in Tanzania were assigned to the control arm and 20 were assigned to the intervention arm. In the intervention arm, the intervention that was provided was CRP rapid diagnostic tests, hemoglobin point of care tests, a pulse oximeter, and this electronic point of care testing plus clinical decision support algorithm, as well as training and mentorship, which allowed clinicians to be guided by these additional tests in order to understand whether or not they should be prescribing antibiotics and other clinical decisions. So this is represented here on the left-hand side where we have our CRP RDTs, our pulse oximeter, and this digital interface where you're able to input patient information, the result from tests, and have an output decision of whether or not you should be prescribing antibiotics. In both intervention and control arms, we saw the integrated management of childhood illness training, weighing scales being provided, MUAC bands to measure the middle upper arm circumference of children, thermometers and IT support. And just the final piece of background information here. So all febrile patients should be tested with a malaria RDT at the health facility as per the national guidelines in Tanzania. So if we look at the results of the impact of this clinical decision support algorithm, we see an almost 3-fold reduction in the likelihood of a sick child receiving an antibiotic in the intervention group. This can be seen on the right-hand side. So in this red bar, we see the electronic point of care testing plus provided a 23% of antibiotics prescribed when participants were treated per protocol. And if we look at usual care, this is quite a bit higher at 70%. So we also saw for the intention to treat where everybody who was not treated per protocol, so individuals who are not treated using the electronic algorithm, if we assume that they have also been given antibiotics, a bit of a conservative estimation here, we see the intention to treat analysis also showed a reduction in the likelihood of antibiotics being prescribed, which we can see on the right-hand side here, where 42% of individuals were prescribed antibiotics compared to 73%. Clinical failure at day 7 did not increase in the intervention group despite a reduction in antibiotic prescription. A key finding here is also that 25% of patients in the intervention arm, where this electronic algorithm and the support tool were provided, were not managed using the support tool. So this just highlights that when we're looking at digitally connected tests, it's important to provide a digital tool, but it's also equally important to provide training and supervision, mentoring, and allow individuals to actually use these clinical support tools. So that concludes our 3 case studies, and next we'll be looking at the next steps for our Digital Health Hub for AMR Grand Challenge. So here our Grand Challenge is to develop a clinical support tool that will connect rapid tests for AMR into electronic patient health records. We have 3 steps here. First of all, capture. So capturing patient data, capturing RDT results, whether that's through an image or an outcome, and capturing geospatial information such as location of where the test is being carried out. Secondly, we have classify. So using those machine learning algorithms that Rachel was discussing earlier to classify our RDT results and incorporate those results into guidelines. So there are some quite complex guidelines that are regularly being updated on antibiotic prescription. And here it's important to take our RDT results, incorporate them into the guidelines, and provide a recommendation for a clinician whether or not to prescribe antibiotics and which antibiotics. And finally, connect. So we'll be exploring features around data security and privacy when using very sensitive clinical records. We'll be connecting into e-patient health records within the NHS and into data dashboards. So technically, how we'll be achieving this? Capture, we'll be looking at different models that allow for object detection and segmentation. We'll be classifying our results using machine learning algorithms trained on real-world data as well as synthetic data. Connecting into NHS electronic patient health records so that we are achieving that data capture. And we'll be working with key stakeholders within this hub to co-create this app and this tool with end users and behavioral scientists. We'll also be developing a training and public engagement tool. We'll be exploring key issues around data privacy and security to ensure any clinical data that is captured is being managed securely. We'll be exploring different tests. On the right-hand side here, we can see a few different AMR RDTs. The first is our C-reactive protein RDT. The next is a qualitative test that distinguishes between a bacterial or viral infection. The next is the CARB-X test, which has a very complicated readout, which really needs this digital support tool. And we'll be looking to the future for procalcitonin RDTs and fungal infection RDTs, and working with other stakeholders within the hub to really understand the frontier of AMR RDTs and how we can support using these digital tools. We'll be focusing on different settings, so within primary healthcare, secondary care healthcare, animal health and environmental testing, and also different devices, so which devices are being used within the NHS with our users and how can we support for those devices. So next on to the further reading. So first of all, we have the deep learning of HIV field-based rapid tests, which is the first case study on HIV RDTs. Second is the visual assessment of RDTs that took place in the DRC. Third is the digital health algorithm, which we've just explored in Tanzania. And finally, just to mention that there are 2 new UCL-led centres for doctoral training that are being launched. Tech for Health, and more information can be found at this site, and one on antimicrobial resistance to be launched in 2025. And if anything in this lecture has piqued your interest, please do get in touch and follow up with these links, and keep an eye out for these exciting new centres for doctoral training. And finally, just to finish with these acknowledgements, so to all of our collaborators and funders on these grants that's allowed us to kind of pursue this incredible research. So first of all, the EPSRC for UKRI Digital Health Hub for AMR. Lots of the HIV work that was presented was funded by iSense, again, an EPSRC, IRC, and early warning systems for infectious diseases, and a second on agile early warning sensing systems for infectious diseases and AMR. And finally, the Medical Research Council, or the MRC grant, M-Africa, which really supported us with that collaboration with ARI. Yes, so to finish, we are always open to collaboration, so please do get in touch. And here are the teams who've supported all of this research and some links to our research websites that you can follow up on. And at the bottom here, we have all of our key collaborators. So finally, thank you for listening.